Okay. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. My name is Baan Alzuhair. I'm a second-year medical student. And today, inshallah, I'll be giving my first PAL lecture, and it's about control of breathing. Here you can see my email and my phone number. Feel free to text me with any questions if you have any. Very approachable person, so even call. I don't care. Okay. So, Bismillah ar-Rahman ar-Rahim. These are our objectives for today, inshallah. We're going to take the neuronal control of breathing, chemical control of breathing, acute and chronic hypercapnia, and acute and chronic hypoxia. I know hypercapnia and hypoxia can sound like the hardest parts of the lecture. They're actually the easiest. And neuronal control and chemical control, we have two subtitles under each, okay? And we're going to take each one at a time, okay? So we'll start with neuronal control. We have two parts of neuronal control, the respiratory centers of the brainstem and the pulmonary reflexes. Okay, so before I start, please feel free to stop me at any time if you have any questions. Okay, so the respiratory centers of the brainstem, they're actually just fancy words to describe a group of neurons in the brainstem. The brainstem is a part of the central nervous system, as you can see a picture over here. I'm not going to go into detail into it, but I just want to orient you. We have a midbrain, the pons, and the medulla oblongata, and it's found like almost in the back of your head. Okay, so it's an interconnected group of respiratory neurons in the medulla and pons. The neural information go from your respiratory organs to these centers in your brainstem, and they also go to your cortex. Your cerebral cortex or your brain takes care of your voluntary control over breathing. Okay. Also, Dr. Shams mentioned accessory muscles in this lecture. I'm pretty sure you've taken accessory muscles in anatomy lectures, but we're also going to mention them here. So accessory muscles, the inspiratory and the expiratory accessory muscles. The inspiratory, we have the scalene, the sternocleidomastoid, the trapezius, and the external intercostal muscles. The expiratory, we have abdominal muscles and internal intercostals. Okay, so when you're breathing at rest, like you are right now, you only require muscular efforts in inspiration by inspirational muscles, which I'm pretty sure you took by now, which are the external intercostals and the diaphragm. Okay. So the accessory muscles, the inspiratory accessory muscles, are used when we have bilateral or on both sides paralysis of the diaphragm. The diaphragm is a dome-shaped muscle, and when it contracts, it flattens and it pushes onto the abdominal organs in order to let the lungs inflate as much as they can, okay? So people with bilateral paralysis of the diaphragm, the accessory muscles, the inspiratory accessory muscles work overtime in order to, well, keep them alive, okay? This is the neuronal flow or the information flow from your respiratory organs to your brain centers or brainstem centers and back and forth. First of all, the information goes from your respiratory organs, such as the lung, the airway, and the pharynx. They go to your brainstem, and we have specific nuclei or specific places where the information goes. We have three over here, as you can see in the picture: the pneumotaxic center, the ventral respiratory center, and the dorsal respiratory center. We're going to take each one and the details we're supposed to know by this time. And this is called the afferent pathway, okay? We have another pathway, which is the efferent pathway, and that's information going from the respiratory center and the brainstem to your respiratory muscles, telling them what to do, contract more or relax more, whatever the situation is, okay? So now we'll start with the groups that we have in the brainstem. As we said before, we have a pneumotaxic center, we have a ventral respiratory group, and a dorsal respiratory group, okay? We're going to start with the ventral respiratory group. The ventral respiratory group has a nuclei, has like 3 nuclei, okay, under it. I'm sorry, I don't have a mnemonic for this. You're just gonna have to memorize this. So the nuclei under the ventral respiratory group include the rostral nucleus retrofacialis, the caudal nucleus retroambiguous, and nucleus paraambiguous, okay? The ventral respiratory group contains both inspiratory and expiratory neurons, and it sets the basic rhythm. So it controls your inspiration and expiration, okay? It also plays a major role in the overdrive mechanism. What is the overdrive mechanism? It's a mechanism that is triggered by your extra need for breathing. Okay, like when you're exercising, when you're running away from, let's say, a lion, you need to breathe more. Okay, and that extra need for oxygen is controlled by the ventral respiratory system or the ventral respiratory group. Okay. It also is included, or it controls the cardiorespiratory coupling. Okay, I know it sounds or looks like a really long term, but it is basically the events that are happening in your cardiovascular system are affecting or will affect your respiratory system. Let's say the patient has hypertension. Okay, there are many cases where this is true. Okay, but we'll just start with hypertension. So the person's blood pressure is high. Okay, the high blood pressure will stimulate the baroreceptors that are found in your carotid. Okay, when you stimulate the baroreceptors, that's going to tell your heart to slow down because the blood pressure is way too high. Okay, how is it going to do that? It's going to stimulate the sympathetic nervous system. The sympathetic nervous system is going to be activated. What is it going to do? It's going to cause your heart to beat more, and it's also going to have an effect on your respiratory system. It's going to cause dyspnea, okay? It's going to lead you to breathe more, all right? That's how any event that is happening with your cardiovascular system will affect your respiratory system. And this connection between these two systems is controlled by the ventral respiratory group. Right. Other situations other than hypertension include heart failure, anemia, exercise, all of that stuff. Okay. So we're done with the ventral respiratory group. We're going to go to the dorsal respiratory group. The dorsal respiratory group has another name, which is the nucleus tractus solitarius. Dr. Shams mentioned something. I'm going to mention it as well. I'm not pretty sure how important it is for you at this stage. Like in our year, it wasn't as important, but he mentioned it and we memorized it, even though we didn't know what he was talking about. So the nucleus tractus solitarius, or the NTS, has inputs that are coming from two cranial nerves. It's called these two cranial nerves are called the glossopharyngeal and the vagus, the 9th and the 10th cranial nerve. Okay, these two nerves bring in sensory information from the peripheral chemoreceptors, the baroreceptors, lung receptors, which the lung receptors are divided into two classes, stretch receptors and nociceptive. Nociceptive means pain, okay? So as I said, it integrates sensory inputs from the airways, lungs, and chemoreceptors, and it senses stretch and pain from the lungs, okay? That's all about the dorsal respiratory group, pretty easy. Okay. Our last group is the pneumotaxic center. The pneumotaxic center, as you can see here, it's found in the upper pons, okay? And it's located dorsally. So this is the dorsal side, this is the ventral side, or posterior, anterior, or back and front, okay? It's located dorsally in the nucleus parabrachialis of the upper pons. Again, you're just gonna have to memorize these, I'm sorry. Okay, so the pneumotaxic center is going to control the switch off point of the inspiratory ramp. Okay, so it controls basically how much you breathe in. Okay, so يعني, try to breathe in now. Breathe in as much as you can. When you breathe in as much as you can, you get to a point where you cannot breathe in anymore. Your chest starts to hurt. You inflated your lung way too much. That point where inspiration is cut, that's done by, or that's set by the pneumotaxic center. It does not let you inflate the lung more than you should. The problem with the pneumotaxic center is it has to be balanced, okay? You cannot send too strong signals or too weak signals. I'm gonna tell you what happens when it does either, okay? So when the pneumotaxic center sends strong signals, okay, your breath is going to be cut prematurely. You're going to take short breaths, okay, high frequency and low volume. You're not going to be able to breathe in as much as you would like to. So you're going to breathe like this. You see, the frequency is really high, but the volume you're breathing in is actually small. You're not getting as much air as you would like to, okay? That's if the pneumotaxic center is working overtime and sending strong signals. But let's see if what would happen if the pneumotaxic center would send weak signals. It's not working as it should, okay? So what would happen if that happens? Your breath is going to be deeper than it should. Let's say deeper in local terms, okay? You're going to breathe in more than you should. You're going to inflate your lungs more than normal at rest, okay? So your breaths are going to be only 3 to 5 breaths per minute. You're going to breathe in a lot, the volume is going to be a lot, and the frequency is going to be very low because you don't need more air than you're already breathing, okay? And when it sends strong signals, as we just said, your breathing rate will be 30 to 40 per minute, which is also not normal. That's a lot per minute, okay? So we're done with the pneumotaxic center. Okay, we're done actually with the respiratory centers of the brainstem. Now we'll start with the pulmonary reflexes. We have 4 pulmonary reflexes. We'll start with the receptors. We have slowly adapting stretch receptors and rapidly adapting stretch receptors. The slowly adapting stretch receptors, they're innervated by large myelinated vagal fibers, okay? They're found in the airway smooth muscles, and they're activated by lung distension, breath holding or lack of movement, and lung deflation below FRC, okay? So let's imagine this is the receptor. This is the stimulus, okay? I'm stimulating the receptor, and it's firing at a very high rate. It keeps firing for a while until the receptor is like, okay, maybe this is my new normal. Maybe this is not so bad. And it starts to adapt to the stimuli, and it starts firing at a low rate. It's like it got used to being stimulated, okay? But focus with me here. This is the main concept. But slowly adapting stretch receptors, it takes them a while to adapt, okay? The rapidly adapting stretch receptors, they just fire a little bit and then they get used to it. So they adapt to the stimuli very quickly. But the slowly adapting, they take a while, okay? And the stimuli we're talking about here is lung distension, breath holding, and lung deflation below FRC. What do I mean by this? Let's say you're holding your breath. Can you actually hold your breath until let's say for a day? You cannot. You cannot hold your breath. You cannot exhale all of the air in your lungs, right? I think you took this. I think one doctor told you this. I don't remember who exactly. But you cannot completely deflate your lungs. This is your body's way of, well, preventing you from killing yourself. You cannot hold your breath for too long. When we were kids, we would be very angry and we would throw tantrums and we will hold our breaths attempting to, unalive ourselves. That never worked because, well, it doesn't work that way. So the slowly adapting stretch receptors, they stop you from holding your breath way too much, okay? You can hold your breath and then your chest starts to get painful. That's your body telling you to stop holding your breath and breathe like a normal person, please, okay? So the lung deflation below FRC, sometimes we try to deflate our lungs, like we take out all the air in our lungs like this. See, I took all the air, not all the air, but as much air as I can from my lungs, okay? We get to a point where we cannot exhale anymore. We cannot take out any more air. And that point is set by the slowly adapting stretch receptors, okay? So the rapidly adapting stretch receptors are also myelinated by vagal fibers, okay? And it's found in the airway epithelium. They're activated by lung distension, just like slowly adapting, and irritants, okay? It causes gasp and bronchoconstriction, and it's involved in the cough reflex. So when you breathe in air, let's say, and it has dust, okay, you're immediately going to cough it out. And what's going to stimulate that cough reflex when you breathe in dust or whatever it is that's found in air, that's mediated by rapidly adapting stretch receptors, okay? So as I explained in the beginning, the rapidly adapting stretch receptors, you stimulate them just a little bit, they fire and they stop immediately. They're quicker in adapting than slowly adapting stretch receptors. Also, something I didn't mention here, Herring-Brewer reflex. Herring-Brewer reflex is what I explained. It's when you hold your breath for too long and the inspiration stops and you start expiring or exhaling air. That reflex is called the Herring-Brewer. And it also works for lung deflation. When you breathe out way too much air and you stop at one point, you cannot breathe out anymore. Your body stops you from breathing out anymore and it starts inspiration. That's also called the Herring-Brewer reflex. Okay, let's make sure I didn't miss anything. Okay, so the individuals that have lung transplant, okay, they do not reattach the CNS fibers or the autonomic fibers back to the lungs. So the rapidly adapting stretch receptors is not able to send back information, okay, back to the brain and the brainstem. So what they're going to have is no or diminished cough reflex. And because rapidly adapting stretch receptors are activated by irritants, they can breathe in irritants without even knowing it, okay? And not being able to cough it out because they have diminished cough reflex. So what's going to happen is increased or frequent lung infections, okay? The last two pulmonary reflexes, we have C fibers or J receptors and muscle spindles. The C fibers and J receptors are found near the capillaries, okay? They're activated by an increase in interstitial fluid. What I mean by increase in interstitial fluid is congestion or edema. And this also can be activated by pulmonary embolism, okay? It causes rapid and shallow breathing, bronchoconstriction, and cardiovascular depression. What I mean by rapid and shallow breathing is hyperventilation, okay? So the C fibers, the J receptors are innervated by non-myelinated vagal fibers. This is really important for you to remember because Dr. Shams asked us a couple of questions about this. So as you can, if you can remember what I said here, the slowly adapting and the rapidly adapting are both innervated by large myelinated vagal fibers, okay? The C fibers or the J receptors are innervated by non-myelinated vagal fibers, okay? So the muscle spindles are gamma spindle fibers that are found within the muscles. Which muscles? The intercostals and the diaphragm, okay? They're activated by resistance and compliance, and they aid in contraction if the motor activity is impeded during inspiration, okay? So they aid you to breathe in, basically. So what happens if the muscle spindles are contracting way too much or if they're not contracting enough? For example, we have restrictive pulmonary disease. I'm not sure if you've taken the pulmonary diseases yet, restrictive or obstructive, but once you do, this will make sense, okay? In restrictive lung disease, the muscles fail to shorten. Remember, the muscle spindles aid in inspiration. That means the inspiratory muscles are unable to contract. That means you're not able to breathe in as much as you would like to. That's what happens in restrictive pulmonary disease. They cannot breathe normally. They cannot breathe in normally. They can breathe out, fine, but they cannot breathe in normally. So they cannot shorten their muscles because of their stiff lung. That's what happens in restrictive pulmonary disease. Their lung is stiff. They cannot inflate it, okay? And the inspiration stops prematurely, okay? They cannot breathe as much as they can, as I said, okay? But in obstructive lung disease, the muscle spindles continue to shorten beyond normal. They keep contracting. So in obstructive lung disease, they cannot breathe out. It's like the air is getting trapped in their lungs because their inspiratory muscles are contracting all the time. Not all the time, but continuously, okay? And beyond normal. Well, they cannot, I don't want to say they cannot relax because I'm not pretty sure of that, but what I know is that they continue to shorten beyond normal. Okay, this is our first checkpoint. Does anyone have any questions? Okay, I'll repeat the cardiorespiratory coupling. Okay, the cardiorespiratory coupling is basically the events that are happening, the things that are happening in your cardiovascular system, your heart and your vessels, they affect your respiratory system, your airway, your lungs, and the pharynx, okay? So let's say the person has either heart failure, hypertension, anemia, or is just basically exercising, okay? Their heart rate is going to increase because of the sympathetic stimulation. Let me just brief you on sympathetic and parasympathetic. Remind you, parasympathetic decreases heart rate. Parasympathetic is rest and digest. You don't need your heart working overtime. But sympathetic is you increasing your heart rate. You dilate your pupils. You start sweating. Imagine sympathetic is you being chased by a lion. Do you want your heart to be rested and not contract? No, you want it to contract more and pump blood to your muscles, to your heart, to your brain, to the organs that you need most. Okay? So when a situation that leads to sympathetic nervous system stimulation, such as heart failure or hypertension, or basically just exercise, okay, that would lead to your heart rate increasing, but also you breathing more. And when you're exercising, your heart rate goes up, right? But you're also hyperventilating. That's the relation between your cardiovascular system and your respiratory system, that connection between them, that whatever happens here, that's controlled by the ventral respiratory system. That's basically it. Don't overthink it. Is that clear now? Okay. Okay. Do you guys want to take a 5-minute break? Or should we continue? Okay. I guess we'll continue. We'll start with the chemical control. We're done with the neuronal control of breathing, okay? The chemical control, okay? We have receptors and their stimuli, okay? We're gonna take the receptors first and then the stimuli. The receptors, well, it's called chemical control. The receptors are called chemoreceptors, okay? We have central and peripheral. The central are found in the brain, the brainstem, and spinal cord. The peripheral chemoreceptors are found everywhere else in your body, okay? So the central chemoreceptors, they are activated by hydrogen and they're inhibited by cold and anesthetics, okay? They're found in the ventrolateral surface of the medulla and the medullary raphe. Okay, remember the medulla in that picture I showed you? It's the lowermost part of the brainstem. There are 3 groups that are considered chemoreceptors. They're called rostral, intermediate, and caudal groups of neurons. Okay? So an increase in CO2 or the partial pressure of CO2 causes a pH decrease in the CSF. The CSF is cerebrospinal fluid. It's the fluid that surrounds your brain and the structures that are included in your central nervous system. Okay? So a decrease in pH in the cerebrospinal fluid is going to stimulate breathing, basically stimulate the chemoreceptors. Okay? There are some diseases that cause defects in these neurons. These neurons are sensitive to hydrogen. There are some diseases that cause defects in these. Some of these diseases are sleep apnea, panic disorder, epilepsy, migraine, and sudden infant death syndrome. Okay. What is important for you to remember is that the central chemoreceptors for CO2 are not stimulated by hypoxia. What are they stimulated by? An increase in CO2, which leads to a decrease in pH. They're not stimulated by decrease in levels of oxygen. Okay, keep that in mind. The peripheral chemoreceptors are basically the carotid bodies that are found in the external carotid arteries, okay? These are activated by hypoxia. That's the difference. That's how you can differentiate. We had a couple of questions about this, okay? They can twist the question and they're just basically asking you about the same thing. Which one of these is activated by hypoxia, okay? The peripheral chemoreceptors is activated by hypoxia when the oxygen goes below 80 milligrams mercury. This is the threshold. The threshold is 80 milligrams mercury, but significant effects or significant clinical manifestations or like symptoms that appear on the patient only appear when the oxygen goes below 65. But the threshold for oxygen is 80. Okay, keep that in mind. It's also, the peripheral chemoreceptors are also activated by hypercapnia when the CO2 goes over 40 milligrams mercury, and low pH, okay, when the pH goes below 7.4, which is the normal pH for the blood. Okay, this is all about the receptors. Pretty simple, straightforward. Okay, just remember which one is stimulated by hypoxia and which one is not. Okay. We have 4 types of stimuli that stimulate the chemoreceptors we just talked about. Okay, the first stimuli is hypoxia. This is a picture that I got from Dr. Shams's lecture, and he talks about one hypothesis of how hypoxia stimulates hyperventilation. This cell is called a glomus cell, okay, or a type 1 cell, and it's the primary oxygen sensing cell that's found in the chemoreceptors. So the hypothesis says we have potassium channels on this cell, and these potassium channels are sensitive to oxygen changes in the blood. So when we have low oxygen or low pH, low intracellular pH, okay? So 2 things can block these receptors: low oxygen or hypoxia and low intracellular pH. These 2 stimuli can block these receptors or channels, okay? When they block the potassium channels, they block the potassium outflux. And I'm pretty sure you've taken action potential by now in MSK, okay? So when the potassium outflux is blocked, you're gonna have depolarization inside this cell, okay? And depolarization is going to activate calcium channels. When calcium channels are activated, calcium will enter the cell and will cause the exocytosis of neurotransmitters. The exocytosis of the neurotransmitters will bind to their receptors on the neuronal end, and that will cause action potential. And that's how hypoxia stimulates hyperventilation, okay? This is the theory of how hypoxia stimulates hyperventilation. That's it, okay? But it's really important for you to remember which channels are activated by hypoxia. These are the potassium channels, okay? This slide, I got it from Dr. Shams's lecture also. The point of this slide is to show you the difference between the response, your body's response to hypoxia if the CO2 is kept constant, which is not actually possible. Let me tell you what happens, okay? When you have hypoxia, your body is stimulated to breathe more, okay? You're breathing in more air, you need more oxygen, okay? As you're breathing in, you're getting in more oxygen, but you're also breathing out more CO2. So your oxygen is increasing, which is what you want because you're hypoxic, and you're breathing out more CO2. So the CO2 is decreasing and the O2 is increasing. So the normal line is going to be the red line. The red line is what actually happens, okay? The CO2 falls as you are breathing in more, okay? But if the CO2 is kept constant at about 40 milligrams mercury, okay, your response to hypoxia is heightened or exaggerated. That's why this line is steeper. When you see a steep line, that means the response or the change or whatever it is high or exaggerated or very fast or very strong, okay? This does not happen normally. CO2 is not kept constant in your body because you're breathing in more oxygen, but you're also breathing out more CO2 because that's why CO2 is not accumulating in your body. But the point of this slide is to show you if CO2 is accumulating in your body, it will cause lower pH. And we said before, lower pH would lead to the stimulation of hyperventilation. So now, not that you have just one reason to hyperventilate, which is hypoxia, you also have a decreased pH. Now you have two reasons for you to hyperventilate. That's why when you keep your CO2 constant, your hyperventilation starts immediately, almost immediately. Okay? This graph is really important. So please, if you don't understand this graph, I'll re-explain it. I don't want to move forward until everyone understands this slide. So please tell me if you don't, okay? Okay, I guess by that, everyone understands. Okay. Okay. Okay, the other stimuli, I said we had 4 stimuli, hypoxia, and 3 other stimuli. These 3 are CO2 and pH, exercise, and voluntary control. When you have an increase in CO2, consequently, you're going to have a decrease in pH because an accumulation of CO2 is going to lead to acidosis. The changes in these two is picked up by the carotid body, which is a peripheral chemoreceptor. And as I just said, this is just repeating what I said, okay? How does it increase hyperventilation? By increasing both tidal volume and respiratory frequency. Okay, if you increase these two, you're going to hyperventilate. Okay, the second stimuli is exercise. How does exercise cause hyperventilation? It causes it via stimulation of rhythm generator from the cerebral cortex neurons. The rhythm generator receives 2 inputs, okay? And it receives inputs from the cortex, from the cerebral cortex, and from the working muscles and the musculoskeletal system, okay? So the CO2 and the pH, I wanted to say something, I forgot. There is no change in CO2, pH, and O2 in your blood in the first couple of, let's say, minutes of your exercise, okay? It does not change until you cross a threshold. This threshold is called the anaerobic threshold. Well, it basically says in your muscles, they have turned to a anaerobic way of producing energy. Okay, this anaerobic way of producing energy will produce lactic acid. This lactic acid will go into your blood and dissociate into lactate and hydrogen. And we said before that hydrogen stimulates the chemoreceptors into making you hyperventilate. Okay, that's how CO2 and pH and exercise affect your breathing. The last stimuli we have is voluntary control. Voluntary control is tested by a test done clinically called maximum voluntary ventilation. This test measures overall condition of the respiratory apparatus or the respiratory organs, okay, including mechanical properties of the chest and lungs, strength of the respiratory muscles, and flow resistance properties of the airway. So basically tests everything. How it's done, it's measured by asking a subject or the patient to breathe as deeply and as rapidly as they can for 10 seconds. Then calculating the ventilation per minute. For healthy adults, the result is usually 160 liters per minute, okay? And that is it for chemical control. Does anyone have any questions? Okay, would you guys like to take a 10-minute break to pray and everything? Stretch? Okay, so we'll meet here back at, let's say.
Yes, doctor.
Okay. So we finished with the neuronal control and the chemical control. Now we'll get into the easiest part of the lecture, acute and chronic hypercapnia and acute and chronic hypoxia. We'll start with hypercapnia, okay? Hypercapnia is basically the increase in partial pressure of carbon dioxide above 45 millimeters mercury, okay? An increase in CO2 leads to an increase in the hydrogen content in the cerebrospinal fluid, which stimulates hyperventilation, okay? So it stimulates hyperventilation due to its stimulation of the central chemoreceptors and the peripheral chemoreceptors, okay? There's something really important for you. You have to understand this. Acute is when in the beginning, it increases and it stimulates the central chemoreceptors and the peripheral chemoreceptors, both, and it stimulates ventilation. After 12 to 24 hours, okay, the pH of the body is partially compensated by the kidney, okay? Thus, the stimulus of the hydrogen content to the central chemoreceptors is less or diminished, okay? But the stimulation of the hydrogen to the peripheral chemoreceptors is intact. So I'll say this again in another way. In the beginning, we have stimulation of the central chemoreceptors and the peripheral chemoreceptors. Okay, so the hyperventilation is going to be very high because both chemoreceptors are stimulated. After 12 to 24 hours, the pH is going to be compensated, and only the peripheral chemoreceptors are going to be stimulated by then. Okay, so in the beginning, the response is very high. Let me draw a line for you. I'll try my best. So in the beginning, it's really high, and it goes low, and it continues like this. At this point, we have the central chemoreceptors and the peripheral chemoreceptors. It goes down because the pH is being compensated by the kidney. And then here we have only the peripheral chemoreceptors being stimulated. There is a graph in Dr. Shams's PowerPoint that describes exactly this, okay? So the shift between the central chemoreceptors, the stimulation of both to the peripheral changes the response to the hypercapnia by hyperventilation. So in the beginning, you're going to be hyperventilating a lot. And then after the pH being compensated is going to be less, but you're still hyperventilating because the peripheral chemoreceptors are still being stimulated. Okay. So there is something really important for you to understand in this. You as a normal person, you and I, we're normal people, alhamdulillah, our motivation to breathe, or our drive to breathe, okay, is high levels of PCO2. When you have a slightly high level of PCO2, that sets your motivation to breathe. That tells your body, okay, we need to get rid of this CO2 and we need to breathe it out more. Okay, that's the motivation for normal people. But with people with chronic hypercapnia, their CO2 is always high. Okay, and it's the motivation is not as competent as other people. So the body's like, this is the CO2 is always high. We need to find another type of motivation to motivate us to breathe. So these patients are always hypoxic. So their motivation is low O2. When you breathe, you want to breathe in more oxygen and you want to exhale more CO2. So our motivation, normal people, is high levels of CO2. That motivates us to breathe. But people with chronic hypercapnia, their motivation or their drive to breathe is low O2. That's why you do not give oxygen to patients with chronic hypercapnia. You're basically taking away their motivation. Their only reason to live is low oxygen. You give them oxygen, their oxygen is high, their CO2 has always been high, they have no reason to breathe. That's literally what happens. They have no reason to breathe and, well, they die, okay? So it's a really huge mistake if you give oxygen to chronic hypercapnia patients. Okay, keep this in mind. Okay, we're done with the hypercapnia. Now we're gonna go into hypoxia. So there is a sequence of events that happens with hypoxia. The first two bullet points, this is talking about acute. The second two bullet points talking about chronic. It all follows a certain pattern. Okay, so first, when you have hypoxia, we have low O2. Your body's like, we need to get more oxygen in. So the ventilation is going to increase. Okay, the increased ventilation, as I said before, as you're breathing in more oxygen, you're trying to fix the problem, the main problem that you have, you're creating another problem by breathing out too much CO2. As you're breathing out too much CO2, you're going to have alkalosis in your body. That means the pH is going to increase. Now we have another problem. Other than hypoxia, we have another problem, which is alkalosis. How do we fix the other problem? We decrease ventilation. So alkalosis inhibits the peripheral and central chemoreceptors, which decreases ventilation. So in the beginning, it was high. We have hyperventilation due to oxygen being low. And then as you're breathing in more oxygen, you're breathing out more CO2. And we don't want to decrease the CO2 in the body because that would lead to alkalosis. Alkalosis will inhibit the peripheral and central chemoreceptors. And that's going to decrease ventilation. Okay? That's acute. That's what happens when you have acute hypoxia. But if this hypoxia continues on for more few days, okay, the pH is going to be compensated. By whom? By the liver, by the kidney, sorry. Okay, then the ventilation increases to a steady rate, and that steady state can persist for life. Let's say you're living on Mount Everest. No one can, but I'm trying to explain. If you live on high altitudes, your hypoxia is going to be almost the new normal for you. The normal state for you is being hypoxic. So hyperventilation is your normal way of living. That's what chronic hypoxia does. So let's say this again, but with a graph, okay? Here we have the acute, let me use the pen, the acute hypoxia. Ventilation will increase, okay? At this point, this is where your body realizes you're breathing out way too much CO2 and you're causing alkalosis, which is the second problem. This is where alkalosis happens. And now this here, this is the inhibition of the peripheral and central chemoreceptors due to alkalosis and the decrease of ventilation. This is where chronic hypoxia happens. So all of this was acute. Let's use my handwriting. And from here now on, this is the chronic, okay? So this area was acute hypoxia. And when your body realizes you're causing alkalosis, it decreases the ventilation. And then after a few days, the pH is going to be compensated by the kidney. And then you start the chronic period of hypoxia after a few days, okay? As you can see here, this is the steady state I was talking about. This is when people live in high altitudes. They get used to being hypoxic, and they get used to breathing faster than normal people that live, well, on planet Earth. I don't understand people who live at high altitudes. But yeah, this is basically what happens. It's really important for you to understand this graph right here. And if you have any questions, please ask, okay? And we're basically done with the content of our lecture. We're going to start with a couple of questions I added in this lecture in order to enhance your understanding of the concepts. Before we go into the questions, does anyone have any concern, anything they didn't understand, so I can repeat? Okay.
No, thank you, doctor.
It's okay, don't call me doctor, I'm the same. We're all on the same boat. Okay, so let's start with the first question I have for you. I'm going to read the question and you guys type the answer in the comments or unmute and tell me the answer. So a 65-year-old man with emphysema due to 34 years of cigarette smoking is admitted to the hospital due to dyspnea. okay? With further tests, the mean pulmonary arterial pressure is determined to be 45 millimeters mercury at rest. He is hypoxic, hypercapnic, and slightly acidotic, okay? The cardiovascular and oxygen changes are due to which of the following? A, increased arterial CO2, increased parasympathetic activity, decreased alveolar O2, and decreased pH. So what do you guys think? So remember, he's hypoxic, he's hypercapnic, and slightly acidotic. All of these would present with which of the following? Okay, we're having different answers. Okay, so the answer is actually C. Decreased alveolar O2 will cause an increase in pulmonary vascular resistance, leading to pulmonary hypertension. Okay, let's go back to the question. He's hypercapnic, he's hypoxic, and slightly acidotic. Okay, so he's gonna have decreased alveolar O2 because, well, he's hypoxic and he has emphysema, so he's not breathing in as much as he can. Okay. Okay, second question. This question has a table. I'm just gonna read the question and then show you the table. Okay. So a 21-year-old female with a history of heroin use, okay, keep this in mind, heroin use, is brought to the emergency department and is unconscious in an unconscious state by her mother. A heroin overdose is suspected. Her breathing is slow and erratic. Exam reveals a respiratory rate of 7, very low, and a heart rate of 55, also very low. Her pulse is irregular, and arterial blood gas is performed on arrival before she is intubated. What change to the patient's pH, a partial pressure of CO2 and partial pressure of O2, is most likely to be measured? Okay, before I go to the table, please remember she's a heroin addict. Her breathing is slow and erratic. What do you think is the answer? What would happen to her pH or and CO2 and O2? Okay, you guys are correct. You got this one right. Yes, it's E. She has low pH because heroin addicts usually have lower pH in their blood. They're usually acidotic. If they have low pH, of course, they're going to have high CO2. High CO2 actually causes the low pH, and O2 is going to be low. Okay, because her breathing is slow. She's not able to breathe in as much oxygen as she needs to. Okay, so the explanation is heroin overdose causes depression of the respiratory center, leading to hypoventilation. That's why her breathing was slow and erratic. With hypoventilation, CO2 is retained. That's why it's high, leading to hypercapnia and acidosis. An increase in CO2 would always lead to acidosis. And PO2 is reduced, leading to hypoxia. Since this is acute, the kidneys have not yet compensated. All the answers, except for E, obviously, these options include one or more incorrect changes. Okay? Last question. A 26-year-old girl becomes cyanotic and faints after holding her breath for 40 seconds during a temper tantrum. She regains consciousness 30 seconds later and calms down. What effect does the breath holding have on the girl's alveolar O2 and CO2 during the episode? Okay, O2, CO2, and she's holding her breath. She's not breathing. This is the table. What do you guys think? She's holding her breath. She lost consciousness. and then she regains consciousness 30 seconds later. What would happen to her O2 and CO2? Okay, somebody said D. Okay, you guys are correct. It is actually D. Her CO2 is going to accumulate in her alveoli, so it's going to be really high, and her O2 is going to be low because she's not breathing. She's holding her breath because she's angry. Okay, so voluntary apnea or breath holding causes alveolar O2 to decrease and alveolar CO2 to increase due to lack of respiration. Okay, is everything clear? Does anyone have any questions? Okay, so this will be the end of our lecture. Thank you guys for attending.